Dr. Gopi Shah is a pediatric otolaryngologist at the University of Texas Southwestern Medical Center in Dallas. She did her residency in otolaryngology at Thomas Jefferson University Hospital in Philadelphia and her fellowship in peds at UT Southwestern. Her clinical interests are pediatric sinus and skull base, and she loves teaching and is the fellowship director for Pediatric Otolaryngology. She's also a co-host of the BackTable ENT podcast, one of my favorite podcasts. We talk a little about the podcast and then get into the snotty, stuffy, noisy problems that pediatric ENTs see. Like what over-the-counter medications she gives her kids when they're sick with colds, how to tell a sinus infection from just cold after cold after cold, like a lot of our kids see in the winter, when to order a sleep study, and what to look for when trying to diagnose an ear infection. Spoiler, it's not the cone of light.
Welcome to the Physician's Guide to Doctoring, a practical guide for practicing physicians. Dr. Bradley Block interviews experts in and out of medicine to find out everything we should have been learning while we were memorizing Krebs cycle. The ideas expressed on this podcast are those of the interviewer and interviewee and do not represent those of their respective employers. Those on this podcast accept no liability for the outcomes of medical decisions based on this information. As the radiologists like to say, clinical correlation is required. This is not medical advice, and this does not constitute a physician-patient relationship. If you have a medical problem, seek medical attention. And now, here's Dr. Bradley Block.
And now a word from this week's sponsor, Laurel Road.
Since I had my son, paying down my med school debt has become my top priority. I remember holding him in my arms for the first time, looking into his beautiful little face, and just wanting the best future for him. With the Laurel Road Student Loan Cashback Card, my regular purchases earn me 2% cashback when I use it to pay down my student loans, which helps me reach my goals faster and plan for my family's future.
Laurel Road for Doctors. Banking, insights, and benefits uniquely designed for doctors. See laurelroad.com/doctor checking for full terms and conditions. Laurel Road is a brand of KeyBank N.A. member FDIC.
Dr. Gopi Shah, thanks so much for being on the podcast.
Thank you so much for having me, Brad. I'm super excited to be here. It's nice to talk to you again.
You too. So yeah, I was a guest a little while ago on the BackTable ENT podcast, of which you are one of the hosts. So first, just give us a little brief summary of what is the BackTable ENT podcast.
Yeah, so BackTable is a podcasting company. It's kind of, I guess, medical media. It started with interventional radiology. This is my husband's baby. It started with interventional radiology about 5 years ago. And within the last year and a half to 2 years, we started an ENT podcast with it. And the goal is just conversations with peers, peer-to-peer conversations, whether it's clinical topics, professional topics, work-life topics, just so that it's a way to have those conversations that when you go to the meetings and you see that colleague, that resident, that, whoever you trained with, whatever friend, whatever colleague, and you're like, what do you really do about this? Or, hey, I saw a patient and this is, what I saw. And it's not necessarily what the lecture, the panel is about, or maybe it is, but you kind of just get inside somebody's head a little bit just to get their perspective on whatever it is. And so that's the goal of it.
Yeah, I love it. And it's where I get a lot of my continuing medical education too.
Well, I love your podcast because I think that it also is helpful for just overall when you're practicing too, on how to talk to patients, how to run your clinic. And I think I told you this the last time we talked. One of my favorite ones was the EMR specialist, I think from Australia. And just because for me, the EMR and PACE and getting patients in and out and documenting, making sure that that's something that I still struggle with even almost 10 years later.
Me too. Yeah. As much as I was a believer in what, and actually I had 2 podcasts in a row that did a similar topic, and the idea was, just for those who haven't listened to those episodes, just finish your charts. You're done with the patient. Finish your chart. Just finish it. Even though there are people in the waiting room, even though because if you finish your chart, you're going to finish it in 30 seconds or a minute. Yeah. But if you save it for the end of the day, you're going to screw around. You're going to forget some things. It's going to take you, and then you've got an infinite amount of time to finish it. Whereas if you're pressed to just going to finish it, you can do it fast. Yeah. So
the 30-second signed closed encounter will turn into a 5-minute. And if you have 10, it's going to be an extra hour later, as opposed to potentially 20 minutes behind in clinic. Or
exactly. So, okay. So one of the reasons we have specialists and subspecialists like you on the podcast is just to teach us everything that if you were giving a lecture to a bunch of medical students, that you would want every physician to know? So as a pediatric otolaryngologist, I think like sick kids with snotty, runny noses. Now, I'm a general otolaryngologist, so I see that as well.
Yeah.
So if like a pathologist were to come up to you and say, "Hey, I think my kid might have XYZ," like what are some issues that you'd want all physicians to be aware of?
So I think the one thing, and again, whether you're pediatric ENT or general otolaryngologist, that you'll see in kids, the three big ones, I think, one is going to be, when is an ear tube indicated in a kid? The second big one is going to be snoring and sleep disordered breathing in a child. And the third big one, I think, is going to be that noisy breathing in the infant. And so those are, to me, are the big three of what probably, whether you're a general otolaryngologist seeing kids, or if you're in a super specialized academic otolaryngology practice, at least 50, if not 70% of the clinic patients that you see are going to be for those three things if they're kids. And so so those are the big, those are the big problems.
So what are the red flags, right? Like what are the things we're looking for?
So I think in kids, when I think of tubes, one is, of course, the recurrent ear infection kid. And then the other one is going to be the ear fluid and concern for speech delay kid. And they're going to be your younger kids under 4 is kind of when I think of that group for the most part. I think the one thing to remember for the recurrent ear infection kid is, we had those new, and I know they're just clinical practice guidelines, but we had those, and actually there's another updated one, but in 2011 was the big one where, yes, it's the number of ear infections, so the 3 and 6 months or 4 year, but I think that seeing fluid on the day of the ENT visit is very important, because I think that allows you to kind of have one other piece of objective data on your exam to help you decide yes or no. Because and a lot of those families, it's going to be thank you, we didn't want surgery, or no, you don't understand, we're always in the pediatrician's office. Like you're getting it on the tail end that we just finished the Sefton 10 days, the 10-day course 2 days ago. But, and I always tell those families, so the child that has the history, but no fluid, to let's see each other at least in 3 months, but call me. The next time you get diagnosed, call me, let's take a look. I'll get you in within, that week or, 3 to 4 days. Let's take a look and rediscuss. So I do think that seeing that fluid on the day of the visit is important for recurrent ear infections. In terms of ear fluid, so the kid that just has fluid, not pus, and the question is it going away or not, and how is it affecting their speech? And so I always tell families, listen, if the ear fluid started, we can say, okay, it started at the time of this infection, 90% of kids will clear within 3 months. And if the fluid is picked up on routine screening, so they failed a hearing test at school, or they went to the pediatrician's office and they had fluid, 50 to 60% will clear in 3 months. And so that 3 months is kind of that magic time number, unless we're really concerned about speech delay. Or like, hey, I've noticed my child has been saying, huh, what, for 3-4 months, or hey, yeah, I'm worried that he's behind in school a little bit, or he's getting or she's getting in trouble. And then we have a field hearing test and that there's fluid and it looks like there's, that sort of serous stuff that looks like it's old and just been sitting there. You don't always have to wait the 3 months. You could potentially offer the tubes or do a closer follow-up. And so that's kind of my spiel on tubes. Now there is, in terms of pediatric otolaryngology and some of the, I think whether you're pediatric or general, we all see children with Down syndrome as well. That's going to be a big part of our pediatric practice. And I think that, in terms of children with Down syndrome, 50 to 80% are going to get at least one set of ear tubes. And the question is who and when. So what's hard to me, I don't know about you, Brad, but I have had a handful of children with Down syndrome. When we're trying to get tubes in, they brought me to my knees, right? The canal is small. There's that anterior overhang. There can be a weird angle. You can't see. You can barely get a 3.0 speculum in.
Yeah, you might can't get the tube. The speculum is so small that you can't get the tube through it.
Exactly.
So you stick the tube in the ear canal and then the speculum.
And then you have
your
rosin.
And then you got to somehow manipulate it through. Yeah, it is. Yeah,
and
it is a challenge. It's a challenge. And sometimes you can't even get it in. Sometimes you can't
Absolutely.
even get it in.
Absolutely.
Yes. Yeah,
And
it can be a real
so
big
for
challenge.
it can be. And so for those kids, and also, there's a complex, so not just difficult anatomy, but a lot of, there's a big spectrum in terms of cardiac conditions and how sick a child with Down syndrome may be in terms of anesthesia risk, as well as, they have fluid on their, I don't know, 6-month hearing screen. I'm not going to just go ahead and let's plan for tubes. I'm going to wait it out a little bit, give them some time to see, for the young ones, I try to wait a little bit longer.
Yeah, a little growth and development
Yes,
might help it to
might
resolve. It's
exactly.
the end of this winter, cold and flu season's going away.
Absolutely.
Yeah, yeah.
Yeah. So that's kind of my spiel, I guess, overall in terms of tubes and
Well,
fluid.
something I would add to that would be, one, it's important to recognize that the ear exam is hard. It is
Mhm.
hard.
It is
Like,
hard.
we've looked at thousands of ears, but one thing that Gopi and I have an advantage is, even after we were done with our training, we have audiologists at our disposal. We have tympanograms at our disposal.
Yes.
So if we're not sure, is that fluid? Is it not? I'm continuing to learn what fluid looks like in all different sorts of looking ears. Why? Because I have something that double checks my work. So I have
100%.
something that, and plus I have the advantage of looking at adult ears as well. So I see these big giant ears that that are much easier to look at than a wiggly screaming 2-year-old, right? You have that kid that comes in with a snotty runny nose,
Mhm.
and it's a struggle to restrain them to even get an ear exam. And so you look at the ear, and the ear is bright red,
Yeah.
but then you got a normal tympanogram. And the ear's bright red because it's just hypervascular because the
They're
kid's bearing down.
crying and they're
Yes.
crying. Yes.
Right.
Yes.
So I
Yes.
would implore all of my pediatric colleagues, my emergency medicine colleagues, my urgent care colleagues to buy a tympanogram.
100%.
Buy one.
100%.
Because one, you'll be able to double check your work. And two, you'll be less likely to miss something, because there are these kids walking around with fluid in their ears. It's pretty translucent fluid, so it's hard to see.
It's hard to see.
And so this is going to be how you can differentiate that red eardrum is just from bearing down in a kid who's febrile and screaming and waking up in the middle of the night, tugging at their ears. Why? Self-soothing behavior. So this
Yeah.
can be, really confusing and just hard to diagnose. And so that's
Well-
sometimes the patients that end up in our office too, which is why those guidelines say abnormal ear exam, because it's hard. It's hard
Yeah.
to diagnose.
I think the
an ear infection.
otoscopic exam is very difficult. And I think for me, I still have times where I'll look at the tympanogram and do my exam, and I'm like, oh, okay, it may be a
Yeah.
little different. I use the tympanogram to really supplement and help me think about what I'm seeing, as well as parents like objective data. And so if you can discuss with them that the eardrum can move, if there's pressure when you're taking away pressure, and that their ability to clear that pressure and equalize, that's a good thing. And
Yeah.
so
How much fluid? 0.3 cc. I'm not sure what they're really asking when I think they're looking for more like a lot or a little.
Yeah.
But if you have a
Right.
tympanogram, yeah, you can be like,
There's
oh, it's
something
negative
there.
300
Mhm.
and normal is, 100, negative
Yeah.
100
And the only
or
thing I would
depending where you
say,
are.
the only thing I would say about the tympanogram is, remember, so it's the probe to the eardrum. So if there's a bunch of cerumen impaction, if the canal is small and angled, or the canal is floppy, right? Which you can have, especially in younger kids, craniofacial kids, and our kids with Down syndrome. Just, every once in a while you'll get a flat tymp and maybe not have fluid. And, if we're not sure, that's where I do think it's okay to papoose and take a look with a microscope. If you're trying to figure out surgery, no surgery, what's exactly going on, or let him try to do cerumen removal versus, hey, let's do a little Debrox or peroxide, go home, come back in a week. Those things are all okay.
Yeah. Yeah. Any other advice for being able to accurately diagnose an ear infection?
Gosh, it's so hard, right? So I think the big difference between, is it just like a mucoid fluid, like snot versus pus, right? Is the eardrum just kind
That's
of
tough because mucoid fluid is white,
is white,
right? And pus is yellow, and there's
Yes.
a marginal difference between
Yeah.
white and yellow.
Yeah. So, and then, but I think that there's maybe a little bit more angry, inflammation, redness to the eardrum, sometimes vascularity, bulging. I think those things make a difference. I've never really gotten into the whole light reflex thing and
No.
not thing. I don't really know what
Yeah.
that is, but
I was
don't
taught
use
that in
it.
medical school. And I hear that in some of my trainees. They're like,
Yeah.
well, it's missing a light reflex. I'm like, that's an excellent
Yeah.
point, but that's an unreliable indicator.
Yeah.
Don't stop telling me
So
about the
I
light
don't know
reflex.
about, what do you think about this, Brad? The one thing I'll sometimes So the one thing that sometimes I'll do, in my kids that are a little bit older, maybe like as young as 6, 7, and it's going to be the kids where the parents are really not wanting an ear tube. They've already had 2 or 3 sets, but maybe there's some persistent eustachian tube dysfunction, maybe near normal audiometry, and speech is okay. I'll sometimes use otoendoscopy. Like I'll put a camera in, and so that way we can all look, whether it's a flex or a rigid. And that way, because I think the parents like seeing the eardrum. Now, it's very helpful if when there's a perf for sure, because they can see how big it is and what we're looking at. And, because they come in and we're just taking a look, whether it's an otoscope or a microscopic exam. I think for parents, it's nice to, again, see what you're seeing and why you're like telling them to come back in 6 months or saying, let's do tubes, or hey, we're going to watch this one area here. And this is why I want us to do close follow up. So that is one thing I started to do a little bit more frequently, not all the time, not every
You
kid.
could use your laryngoscope. You could use your flexible laryngoscope. Just stick that in the
Exactly.
ear. You don't need
Yep.
a separate setup. I mean, this
You
is
don't need.
now we're talking just to the otolaryngologist. Sorry,
Yeah.
everyone else.
So,
But for everyone else, I think the tuning fork test can actually be I don't really know how useful Rena is. I'm not sure about your experience, but a Weber. That's where you put it on the middle of their forehead or on their maxillary teeth to make sure it's clean. And you put it on the maxillary teeth, it actually makes it more sensitive. And if it's louder on one side, now again, this is for the older kids or for the
Right.
adults. But this is a pediatric ENT lecture. So it's really for the older kids. You're not sure what you're looking at. A Weber can really be helpful. Because
Yeah.
the lower frequencies especially are going to be more sensitive for conductive
So
hearing loss in that.
let me ask you, for the ear fluid patient, do you do Flonase and allergy medicine, or do you not do Flonase and allergy medicine? Do you give them anything? What do you like to do? How do you manage that? Or is it just like, hey, we're just going to watch?
If remembering the Academy guidelines, the answer is nothing. Right? Nothing.
But what do you do in
Nothing
your
helps
practice?
fluid. So what do I do in my practice? So it depends. I want to see if there's an underlying condition. So I'll do a nasal endoscopy. But for the non-otolaryngologists out there, I would say manage this symptomatically. Do they have a nasal obstruction? And if they have a nasal obstruction, then you can put them on a nasal steroid because then you're actually treating something. If there's no nasal obstruction, they just had a cold and now the cold is gone, I would say nothing. Now, I also have colleagues that use steroids. They'll put them on steroids, but I don't, I will do nothing unless there's an underlying condition like a sinus infection or enlarged adenoids, because then I'm treating something as opposed to
Yeah.
just giving Flonase. But I've colleagues that will give nasal steroids.
Yeah, I
What
think
about
I
yourself?
agree. I agree with you. I think unless they're, if they have allergic rhinitis, if they're, like you said, nasal congestion, nasal obstruction, something up here in the nose, then I don't, I think a nasal steroid spray can be helpful, at least at minimum for those symptoms. And I always tell the family this may or may not change anything for the fluid. If there's a lot of clear rhinorrhea or sneezing, those kinds of other more systemic allergy symptoms, I might do a little Zyrtec. If they're totally fine, and I totally agree with you, if they had the cold, it's gone, and there's a little fluid left, do nothing. And, I think that some families want something, but many families nowadays are happy with let's watch. Yeah, I don't want to
Yeah.
keep doing
Here's
antibiotics.
the
I don't
plan.
want to
You
keep.
need a definitive plan. And
Yeah,
that's good. We're good as long
yeah,
as there's a plan. Yeah.
yeah,
Yeah. But except for those parents that are like, we're in the pediatricians all the time getting antibiotics. And
yeah,
then that's why you might not wait, right? And
yeah,
you might do tubes.
yeah.
So another question is for those kids, like we're just making it to the end of the winter. Kids are back in daycare,
Yeah.
masks are off. Not like it prevented my kids from getting sick.
Yeah.
Actually, it's a good question for me. I got a house full of snotty noses right now. Um, how do you differentiate a cold from a sinus infection, right? You've got the kids now without sticking a camera up a nose, right? We have the
Yeah.
advantage that we can do a nasal endoscopy, we can see, but, what would your advice be for pediatricians, urgent care, family medicine, where you've got these daycare kids, they've got,
Yeah.
a 4-year-old has a snotty nose all winter. How do you
Yeah.
differentiate cold after cold after cold from a sinus infection that would benefit from antibiotics?
Yeah, no, I think that's really hard. Viral URI to acute sinusitis, bacterial to whether it's actual chronic. Because we know that kids, especially under the age of 3, get 6 to 8 URIs a year. And so, like you said, there was RSV in the class, and there was rhino entero, then somebody had adeno, somebody then had flu. And so how do you know? And I think, some of the questions are, do they get better in between? Does it clear up? And sometimes they'll just say, if the nose is still running, but they're not fevering, they're eating and they're playing, okay, that's a good thing. Is it, is it that it got a little bit better? Now it's worse with fevers and more purulent rhinorrhea, and they just don't look good, don't feel good. And now it's been 3 to 7, 8 days, or in an older kid, I might even give in more like that 7 to 10, then it may be a little bit more like an acute bacterial. I think the one thing, in terms of red flags, and these aren't as common, but I think in an outpatient setting, I think that our colleagues see this more, is going to be, that mild preseptal cellulitis of the orbit of the upper lid, or lower lid, that can sometimes happen with acute sinusitis, even as young as 1 I've seen. And those are some of the red flags where if they have the, URI symptoms, fever, and now the upper lid is red and swollen. And I think if, it is okay to do oral antibiotics for that with very strict ER warnings, because those eyes can blow up overnight, get a lot bigger, a lot harder, a lot swollen, and can turn into something scary like a superior orbital abscess or something, further in terms of that kind of complication.
Oh yeah. In my experience, those happen quickly. Like it's not like, well, they got a cold and then the cold got a little better and then they got a fever. It was more like they had a snotty nose for a day and then just boom, the eye just shut. It's just, it's not the chronic sinusitis that causes these complications. It's an acute sinusitis, and someone that's never had sinusitis before. It can be
Absolutely.
pretty scary.
This is Now, in terms of chronic sinusitis in a kid, right? That's, I think, the $1 million diagnostic question still. Like, we have these consensus statements, we have these, and my little niche is like pediatric sinus, right? But I think that runny nose sinus kid under the age of 7 is actually really hard to tease apart. And I think that, I think that sort of more than 3 months of significant nasal obstruction, mouth breathing, and whether it's either chronic cough can present this way, or thick runny nose that just doesn't get better, maybe where you have to think, okay, is this chronic adenoiditis? Because some people don't believe that chronic, is it chronic sinusitis? What's the difference between adenoiditis and chronic sinusitis?
I mean, without a camera up the nose, you can't tell the difference.
The one thing on your anterior rhinoscopy, and this will happen probably about once every 6 months, I'll get a patient for chronic sinusitis in like a 3-year-old, and it's a nasal foreign body. So that's something that, that's the one thing that I'm like, yes, this is the source. Let's get it out, and your life will get better. I promise. This is the best thing in the whole world. Those are some of my favorite cases. Yeah.
Yeah.
Right.
It's so cathartic. Except it stinks.
It
like as soon as you take it out of the nose, the whole room smells.
It's like a dead skunk. It's an animal. And usually, a lot of times, like you said, you can walk into the room and it smells like, so bad. But so that's one thing. And a lot of times, it's, and the child may or may not have unilateral rhinorrhea. Usually it will be unilateral rhinorrhea that's persistent. When you look in the nose, sometimes you'll see it, but every once in a while it'll get missed because there's a bunch of snot sitting in front of whatever it is. And, sometimes it can be missed as well. So especially because it's not like the kid's going to tell you they put the sponge piece or whatever.
It's always a sponge, right? Like it's a bit of couch cushion. It's something so, yeah. Because I guess a bead or something will be easier to see, but the couch cushion absorbs all that mucus.
Yeah. And so let's say now it's like the 3 to 7 year age group that, they've been on 6 courses of antibiotics in the year for sinus infections. They're all 10-day courses and they get better while they're on it, but literally a week later, the stuff comes back and it's congestion. And usually it's either thick rhinorrhea or cough or something. If I can scope them, I will try to do that because I want to make sure I don't see polyps. I want to see what the adenoids look like. I want to see, is there pus? Is it just clear stuff? How pale is the mucosa? Is this more allergies? And, that depending on what that looks like, if it's like, hey, those adenoids are big and they're red and beefy or there's a bunch of drainage on it, I'm going to go for that first. And that's usually what it is. Now, I think the workup in a kid is very important. I do think, if you're really thinking chronic sinusitis, I think a sweat test to make sure we don't have cystic fibrosis. If once that's ruled out, the other thing that they're starting to do is a nitric oxide test, the nasal nitric oxide. Once CF is ruled out, if that is low, that might be a concern for primary ciliary dyskinesia. So the ear
Right when I was training, and right when I was like the go-to person in my office for ciliary biopsy,
yeah.
because we would send
Where
them
were
to
you getting
Mount
them from?
Sinai. We'd get glutaraldehyde from Mount Sinai, which is not that far from us. I would take this thing that like is meant to clean between your teeth. I'd use that
Little
to abrade the
brush.
mucosa. Yeah, I'd try to get it from the middle meatus.
Yeah.
But I wouldn't do it under endoscopy because you can't hold them
You
still
can't
for that.
hold and
But
do
no, but you
it.
can aim for the middle meatus,
Yes,
and I got
yes.
good tissue. But
Yeah.
they don't do that anymore. It's
Yeah.
now genetic testing. They'll do
Yeah.
genetic testing. Or
They
what
do.
was the other that you said?
So the nasal nitric oxide. So in
Okay.
a non-infected nose, we should have a decent level of nitric oxide in our nose. It can be lower in CF as well as PCD. So usually, once the sweat test is cleared or negative, then we can do that. But they usually, I think it's 5 and up, at least here at our center. And so that's something else. And again, those kids are going to have that chronic otorrhea. This is their 5th set of tubes, and there's snot always coming out of their ears. But those workups are very important because, especially with PCD, I think CF we're diagnosing earlier and earlier, but PCD is still something I feel like can be a late diagnosis between the ages of 2 and 6, and those kids struggle for a long time until that diagnosis is there. In terms of genetic testing, I believe, so 10 years ago, I think there was maybe like not even 12 genes. Now I've heard that there's anywhere between 30 to 50 that they can test for. So it's become a lot more. And usually we have pulmonology colleagues that, if we're really thinking that workup, that's who I send them to for the nitric oxide screen. And then they can help me decide if they want further genetic testing. And if the sweat is elevated, I'll reach out to them and then they can decide about the genetic testing for cystic fibrosis. Other things I'll ask is, immunization status, whether it's up to date or not, and if they've had any other infections anywhere else. And then, in terms of allergy immunology, I have kids. Getting a blood draw in a 5-year-old is a big to-do. So I don't just start ordering a bunch of labs. I actually will send them to my pediatric allergy immunology colleagues for chronic sinusitis or whatnot, and then they can decide if they want to do a RAST and what kind of immunology panel they want to get. Yes, you can get basic immunoglobulins and titers for H flu and pneumococcal, and a lot of times, sometimes they might just need a little bit of a booster. But as opposed to me sticking that and then being like, oh, everything looks normal, I'm going to still send you over there. You know what I mean? Because I don't feel comfortable to say, yeah, you're good. So I'll tend to send those out just because also that's what they do. They're a lot smarter than me when it comes to thinking about the entire picture from the allergy immunology standpoint.
This is their wheelhouse.
That's their wheelhouse. Yeah. And then that's kind of my initial workup, at least. I talk to families about sinus rinses. And so I have to show them pictures. So obviously to me, the youngest, so one of my CF patients showed me, have you heard of the Sinugator, Brad? It's like alligator gator. So it's SINU, but gator. And you prepare the bottle the same way as you would a regular with distilled water or bottled water, and then you add the packet of salt. And then it has a top that you twist on. The top has a little applicator to the nose, and you push a button and it shoots it up. And it kind of is like more of like a power washer, if you will, like a high intensity saline mist almost.
Oh yeah. No, I know what I just pictured an alligator, but
Yeah.
like it's no, like sinus irrigator, sinugator, not sinu alligator. Yeah. Like our chronic sinusitis patients will use that. They'll use that to power wash their sinuses.
Yeah.
Or that's where we'll put their budesonide or topical antibiotics. Yeah. Our adult patients use that. Definitely.
Yeah. And so I think kids as young as 4 can do that.
Wow.
Yeah, it was a 4-year-old patient with cystic fibrosis that introduced me to that. In terms of younger patients, I've had a handful of families use what's called the nasal line, which is basically saline that you have a syringe for. The syringe has like, that nasal, like what they do nasal Versed with the nasal applicator at the tip. And literally on like an 18-month-old, they'll just hold their child forward and kind of squirt it up. And they'll get big, thick slugs of snot out, and that's been helpful. Some families will just use a little blue bulb syringe and just gently. And I understand that not everybody can just jump to those rinses. Like I have kids too, and so I get it. And it may be that the big thing is to not make the child scared of anything close to their nose. We want the child to be comfortable with things close to their nose, whether it's my otoscope, whether it's the Flonase, to just the average
COVID test.
saline. Yes.
Like my 5-year-old is now like, anytime he gets a runny nose, he's like, am I going to get a swab? Am I going to get a swab? He's terrified.
Yeah.
So that has not helped our case.
Yeah, it
Not helped our
hasn't.
case.
But what I tell them to do is get start with saline mist. I think that's maybe the easier one. And I'm like, just week 1, let them play with it. Spray it on
It's
their
like
arm.
a humidifier. Like it's barely putting anything
Spray
up
it
there.
on their face so they're not scared of it. And then week 2, after you've done it and the bottle's a fun thing, then start to help them see what it feels like to get in their nose. And I always tell families the consistency is key. Like I'm going to say, do it twice a day for until I see you in 3 months. But I always tell especially my kids that are older, I'll say, do it Monday to Thursday, right? Before bed, take the weekends off. If you do that for 4 to 6 weeks, it's better than doing it twice a day for 4 days and stopping.
Yeah. Also, if your kids will cry and get upset and then win because you're like, enough, fine. That just reinforces that they can win. And so now it's going to be so much. It's like people at a slot machine, right? Like they're going to keep on, they have to win every so often, not usually, they'll usually lose, but if they win every so often, they're going to stay at that slot machine. And it's the same thing with your kids, right? Like if they win every so often, oh man, it's going to make it that much harder for a long time. So speaking of that, how does a pediatric otolaryngologist treat her sick kids? Like what are the medicines that you have in your medicine cabinet? And we'll see if it's the same as mine.
Okay. Well, so my kids are 8 and 10. So they're a little bit older. I have the cans of the saline mist. And so if it's allergies or more like cold, if they have like a runny nose, I'll at least get them started on that. My older one, will do a sinus rinse, but it's a to-do. Like it takes time because the adult bottle is 8 ounces, the pediatric one is 4. He can get through probably 2 to 3 ounces and then we're done, which is fine. At least something came out. So those are the big things. My older one is dealing with some winter into spring allergies or something. I'm like, I need you to come scope and brag. Cause I'm like, what's happening back there? He's like mouth breathing. And I'm like, oh God, I should know.
Because our trees aren't putting out any in New York. Our trees aren't putting out any pollen yet. Like there's nothing right now. So
we're about to get caked with pollen. Texas, April is just a yellow sheet of stuff on your cars. But, so I might have a Flonase. And then I'll have several cans of the mist. Cause if we've used them, it's been more than like a month or 6, I'll just throw it away and have them start a new one. And that's pretty much it. I have some Zyrtec available, but I don't always use it. My kids don't like taking the medicines and they're not that sneezy. Like it's not that big of an issue. And then I have a bottle of Afrin on hand in case they get a nosebleed. Or some bleed, but fortunately, knock on wood, they're a little bit older now. We used to deal with that a little bit more between 2 and 6, picking that nose and rubbing and itching that dry nose. And I think that may be what we have. I might have a little like antibiotic ointment or Aquaphor for their nose when it gets dry, because they get a nosebleed maybe once or twice a year now. What else am I missing?
Yeah, my kids really haven't had nosebleeds,
Dermabond.
although last time I looked, I turned around and one of them had both fingers up his nose. And then his brothers, I turn around, are imitating him.
Oh
So all
gosh.
six fingers up six nostrils. Yeah.
It's
So
good.
sorry.
It's good.
You said Dermabond?
Yes. I try to keep Dermabond in the house. That has saved us probably 2 or 3 ER visits at this point. Yeah. So try to get those when I can. Put them in my pocket.
Yeah, I'm not so huge on the saline with my kids. I mean, when they've got super snotty noses, I'll use the saline. My oldest is amazing at blowing his nose. The other two aren't. So
That's
my kid's
great.
2, 4, and 5. He's almost 6, the oldest. Um, and he's got asthma, so we've got the Flovent and the albuterol. So when the coughs come,
Yeah.
I scale that up actually. So normally
Yeah.
he's on 1 puff twice a day of Flovent, but when he's sick, I go to 2 or maybe even 3. Now this is not medical advice because it's not FDA approved for that much. But like when to keep him off the prednisone when he's
Yeah.
acutely ill, I'll be scaling up on that. And the albuterol as well. But the medicines for all of them, Motrin and Tylenol. Motrin I rely on a lot more heavily than Tylenol if there's any pain or fever. Just lasts longer.
Yeah.
Then you're not waking up. You're less likely to be waking up in the middle of the night. But Benadryl, I rely very heavily on Benadryl, not for its anticholinergic effects, not to dry up their snotty noses, but just to help them sleep through the night. Like,
Yeah.
because when they're sick, they wake up so many times.
Yeah.
And I think maybe I'm just rationalizing the therapeutic benefits of a good night's sleep because I want a good night's sleep too.
Yes.
But I think there's both, right? Because then the next day they're not zonked since they were up all night. They're not, what's worse than being sick and tired. So
Right.
I use Benadryl on mine, which is FDA approved for 2 and over, if I'm remembering that correctly, although I think the bottle says, ask your doctor if they're less than 4.
Yeah.
And then pseudoephedrine,
Yeah.
good
It's our
old
it's a
Sudafed.
friend. It's our
So I
friend.
don't send them so if they got a snotty nose and it's not COVID and I'm
Yeah.
sending them to school, I'll give them a dose of Sudafed so they're not blowing their nose and quite as snotty and drippy and,
They can breathe.
exactly. And they can breathe better. So that's FDA approved for 2 and over.
Yeah.
So, I can use that on all my boys now, and Afrin too, but Afrin's FDA approved for 6 and over. So I can't use that on them just yet.
Yeah.
But that's another thing. Yeah. When
And
they're
it's limited.
so snotty. Yeah. Right. There's a rebound
Limited.
effect of the oxymetazoline.
Exactly.
So you don't want to use it for more than a few doses. And how many patients have, actually, no, you're pediatric. So you haven't seen the people that have rhinitis medicamentosa.
I have some
Oh.
10, 12, 13. I mean, people
really?
will use stuff, yeah,
Yeah.
because they just want their kid to breathe and not realizing that, hey, there's an addictive aspect to it.
Yeah.
So,
Or if you've got a kid who is flying, you're going on an airplane, squirt them with Afrin.
yes.
And they're less likely to have any problems
Yeah.
popping their ears. Yourself as well
Yeah.
if you're gotten a stuffy nose. So that's
I tell,
that's what I have for my kids in the house.
yeah, I tell families when they're boarding, do the Afrin, and then when the captain's saying we're about to land, do
Yep.
the Afrin because the descent is also something. Obviously, this is going to be maybe that 5, 6 and up. Younger kids, the infants, take your passy, your bottle for takeoff and landing. Landing's going to be harder. Is that right? In the air?
Yeah, landing.
Landing's going to be
Yep,
harder.
because the pressure is increasing.
Thank you. Yeah. And so, and then between like 2 and 4, have them see if you can make them drink something, suck on something. That's a
Yep,
bit of a, chew, if they can chew sugar-free gum or something. But that, again, that age, we don't want them to choke on that either. So
Yeah,
maybe not.
snacks and
Yeah.
bottles and lollipops and
Yeah.
yeah.
So
That's
tell
what
me
we do
what your
ours.
thoughts are, because I'm sure you get a lot of kids as well for the child with recurrent croup, otherwise healthy. They've had 4 episodes of croup in the last, January to April, and they're like 3. What do you do with those kids? Otherwise healthy, no past intubation history, do you take looks or how do you counsel the family? What are your thoughts on
So
croup?
I don't really do pediatric airway. I don't do pediatric airway. So, I'll diagnose laryngomalacia, those noisy
Yeah.
breathing, 4-month-olds and tell them, we'll watch them for a while. But, I don't do direct laryngoscopies. So I'll be
Yeah.
referring that to my pediatric otolaryngology colleagues. However, my experience has been most of that is asthma masquerading as croup, where they'll get the croupy cough.
Yeah.
Croupy cough, worse at night, and it responds to albuterol.
Yeah.
Like if they haven't tried albuterol, like, because typical the history is they're having trouble breathing. They might even be stridulous, right?
Yeah.
And they get prednisone and they get better. Well, the stridor really isn't a hallmark of asthma, but
Right.
I've seen plenty of kids with that croupy cough that respond to prednisone, but they've never actually tried albuterol. See, they try albuterol and suddenly
Yeah.
it gets significantly better. So that's the first thing I'll do is I'll try them on albuterol while it's happening,
Yeah.
and see if they
I think that's
respond.
a great point. I think that's an excellent point because, it's hard for me. It's hard to know, are we going to do a DLB? Like take a look, direct laryngoscopy, bronchoscopy, and why, right? So if there's, no intubation history, like when they were born or ever had surgeries, things like that, croup happens and it happens between, as young as 1 to 2 to 4, 5, 6, and it tends to run its course eventually. And so a lot of times it's diagnostic, like your airway looks normal but the virus likes to go right below the vocal cords, but like you said, it might actually not even be that. It might be some asthma or some reactive airway overall as opposed to croup. And so in terms of when to take a look, for me, I think it just depends on, are you in and out of the ED all the time? How bad is it getting? Are we worried about DSATs? Is it more than just having to go to the PCP's office and getting an oral steroids? And then how worried are you? How comfortable are you? And is the child when these episodes happen? And if it's pretty like in extremis and there are more other, there's something weird about it or something that's like a red flag, like, constantly in the ED or just something, then I'll take a look. But majority of the time, it's usually normal diagnostic. And sometimes that information is helpful because you just have to work, we have to work
Yeah.
through it.
Then you can relax. Like,
Yeah.
yeah, as a physician, what's your sphincter tone? Like, are you going to be able to,
Yeah.
my rule is if I'm going to lose sleep over this, I've done something wrong. Like
Yes,
if I'm worried
absolutely.
about this kid, then, I mean,
Yeah.
no, granted, there are plenty of
Yeah.
patients out there that we just worry
Yes.
about. Right. But like, did I worry that I may have mismanaged this, right? If I'm worried enough
Yes.
about this kid, they're like, oh man, they might have been ED. This might actually be something. Then that's when you
Yeah.
take a look. With the
Absolutely.
caveat that I'm not the one taking the look, I'm
Right.
referring to you.
Well, and differential in that age group can be things like airway foreign bodies, right? That maybe there was some history of choking, like a couple weeks ago, and they have intermittent stridor, things like that. That's the other big one that we don't want to miss because you could end up with a bad pneumonia and intubated. I've seen that. Thought to be asthma, intubated, had a popcorn kernel, had a choking
Oh.
event on Cracker Jacks 2 months prior, and then I've also seen where maybe it happened a while ago, but sometimes those foreign bodies will move around a little bit. And so it doesn't create a pneumonia necessarily, but there's that intermittent cough when it's kind of bouncing around between the right and left main stems, or you know what I mean?
Oof.
I've seen that too. And then in terms of noisy breathing, I know in the general as well as in the pediatric ENT clinics, we're going to see a lot of laryngomalacia, that otherwise healthy baby that is noisy, and it might start as early as 2 to 4 weeks of life and it gets worse between 3 to 6 months and usually resolves, of course. I think the the NICU history, if they were ever in the NICU, breathing tube intubation, all that stuff's very important. And then I think the big things are, how are they feeding? Are they gaining weight? Do they look comfortable? Are there signs of reflux? What came first, reflux or laryngomalacia?
Right.
Chicken or the egg?
Right. When I was training, I think it was everyone with laryngomalacia got treated for reflux. Right.
So,
and now it's
yeah.
like, well, these things tend to run together, but it's not
Yes.
necessarily the
Yeah.
reflux causing the
Yeah,
laryngomalacia.
yeah. Or is there such bad laryngomalacia that you're breathing,
Yeah, you're
taking that
dropping
as-
your intrathoracic pressure and you're
Yes.
sucking stomach contents into
And
your
you're
throat.
right.
Yeah.
I think that we're a little bit more thoughtful about whether we throw Pepsid at the patient or not, or how are they doing clinically. And if there really is reflux, do I want to manage it? I might actually send them to a pediatric GI. And I think all of those things are okay. The International Pediatric Otolaryngology Working Group has like laryngomalacia guidelines. And, I think the big things to remember is feeding, sleep disorder breathing. Are they like stridulous, retracting, noisy, having trouble breathing when they sleep? And, every time the other one is every time they get sick, you're in the ER, or are they stopping breathing, turning blue, purple? All of those things is kind of where we have to then be a little bit more aggressive. And the aggressive may be, okay, we're going to start with a little Pepsid, get you referred. Are you having concerns for choking or, pacing? I might do a swallow study or a feeding eval. I have an amazing pediatric speech pathologist, Ashley Brown, here in Dallas. And for Ashley, she gets 1,000 like messages from me just because I find pediatric dysphagia really difficult. And so I always ask her like, hey, video swallow, or would you just want to do a feeding eval first, because again, a video swallow is fluoroscopy, it's a little radiation.
Radiating
so,
which your husband, an interventional radiologist, would be like, oh, come on, that's nothing. but these kids are little peanuts.
Exactly. And so, those are my thoughts on laryngomalacia.
Yeah. The noisy, and just for our non-otolaryngology colleagues, I would just remind you, in kids, the larynx sits really high. That's one of the reasons that they can lie down and drink, and you can't, because the uvula interdigitates with the epiglottis, and it allows the food to avoid, or the milk to avoid the larynx.
Which can sometimes make the scope exam really hard because it's like soft palate and uvula getting in the way of seeing the larynx.
Exactly. Yeah.
And their stuff is a little bit more anterior and everything's tiny.
It can be hard to, like a laryngeal cleft you're trying to see with a 2 millimeter flexible scope.
Yeah. Or does the cord move? I mean, what I find that's helpful now, sometimes what I'll do is, so I'll record it. And then what I'll sometimes do is on the tower, I'll record it on my iPhone, and I'll go through it with my hand slow-mo to see, can I tell if there's mobility or not? Because sometimes there's just so much crying. Sometimes there's tension because they're mad, and then you can't tell. And to me, a vocal cord weakness or paralysis can be, whether it's unilateral or bilateral, unless it's super obvious, it can be really difficult. And something like a bilateral vocal cord paralysis is not common, but it can happen. And sometimes they'll be otherwise healthy babies. And to give that diagnosis, that's a big deal, because you may need an MRI for a QRE, or you may, if they're not feeding growing, you may end up having to consider something like a cricoid split or a trach, depending on the kid and what center and who's doing what. I mean, I'll do pediatric tracheostomies, but I'm not one of our main airway people. So to me, that actually has been very helpful. And the reason we started doing that is that on our flexible scopes, there's actually an iPhone adapter. So for consults in the hospital, instead of carrying a big case around, you can get the adapter, put it on the eyepiece of the Flex laryngoscope, record it, and then what's nice is you can review the scope, show your partners, and then also slow it down to really get a look. That's a nice little...
In our hospital, we have disposable scopes.
What?
So every time you scope someone, you throw it away.
That's amazing.
It's insane to me.
Oh
it's
my
insane.
God.
Like just the waste of resources, like rather than cleaning it. Although somebody at some point did a cost analysis and decided that was the right thing to do. But yeah, we don't walk around with the case. I call ahead of time, and they bring from 2 different parts of the hospital. One place has the screen and one place has the scope, and they have to know what I'm talking about. And But the reason that I brought up the height of the larynx is because a lot of those kids present with stuffy nose. They're like, the kid's congested. Well, are they taking a pacifier? Yeah. They're drinking from a bottle or nursing? Yeah. Okay. They don't have congestion.
Yes.
Their nose is working just fine, but it sounds like that noisy breathing sounds like congestion because the larynx sits so high that it almost sounds like it's coming from the nose. Yeah. So yeah.
So before we end, I feel like we got to talk about the snoring kids real fast.
Okay.
I don't know. Is it boring? I feel like sleep disorder breathing for pediatric for pediatric ENT or general ENT, we see those kids, and I think sometimes the question is, do you get the sleep study? Do you just take do the TNA? Do you just do the adenoids? And I think in terms of where you do it, inpatient,
total TNA, intracap.
So in residency, I did intracaps, In fellowship in my practice, I've been doing totals. However, I think in a high risk child that potentially might bleed and in a really young child, I think intracap is the way to go.
Okay.
Yeah. What about you?
I did not train doing intracaps, but I do mostly intracaps now.
Yeah. Do you
With
do the co-blator
with
or
good results.
microdebrider?
I started off doing the microdebrider, and it was just a bloody mess. So yeah, I just
Yeah.
used the co-blator.
Yeah. It's
Yeah.
nice.
Yeah.
It's nice.
It's great. And the
Yeah.
recovery is so easy. And some of those kids where you're like, do I just do the adenoids? Yeah, but the
Mhm.
tonsils are really big too. Yeah, but do they have OSA or is it just bad snort? Like it makes the decision making easier because the risk is so low of
Yeah.
a bleed or
Right.
dehydration. You don't see dehydration in those kids where you do
Yeah. Okay. In your
an intracap.
experience, though, how often do you see tonsillar regrowth? Now, I think reported it's like less than 2-3%.
So how are you defining it? Like, is it recurrence of sleep apnea, or is it just like, yeah, it looks like they grew back a little bit?
No, I
Because
think that's a great question because
yeah,
does it matter? It's just like adenoids, right? They
yeah,
grow back. We shave
yeah,
it. It's a low and mowing the grass.
exactly. But so
Yeah,
yeah, how many revision tonsillectomies have
absolutely
I
correct.
done?
Mhm.
One of my own and one of someone else's, and I've been in practice for over 10 years. So
So
and
I think that's
I
a
see a
great,
lot of kids in my
I think
practice,
that's a
not as
great
many as you.
point. No, I think that's a great point because I will tell you in a group where we do totals, I've probably done with totals one of my own and one of somebody else's in the last 10 years. So that could be, you know what I mean?
Yeah.
I think it's a good way to.
Yeah, like the study on peritonsillar abscesses, the rate of needing to do an IND was like 6% for antibiotics and steroids and 6% for IND. Both needed an IND like in only 6%. So it
Yeah.
showed that the two were equivalent. There's an interesting
Yeah.
parallel there. Um, so um, yeah, so I've been the only time I really won't shave is if I'm concerned that there will be persistent sleep apnea afterwards. And so if there's
Yeah.
some other condition that's predisposing the kid to sleep apnea, I'm going to want to remove more tissue. So
So
removing more tissue, I think is
obesity.
yeah. So if there's obesity or some craniofacial abnormality or something else that's making me think that it's not, or if the tonsils are really small. The Academy guidelines are saying, I think it's the Academy guidelines recommendation, or maybe it was my CME question that I now have to do. That even if the tonsils are small, the first line of treatment is
Is TNA.
adenotonsillectomy.
Yeah.
Yes, you're not going to do it
So I always
intracap on
tell,
2+ tonsils.
yeah, I always tell families that like tonsils are kind of like belly buttons. Do you find that to be true? I mean, so you get the atlas, right? And
Oh,
you're
you got innies and
clamping,
outies.
right?
Yeah, yeah,
Yeah,
yeah.
they're like belly buttons. And
Yep.
like, and I do think that when kids go to sleep, the innies may fall in a little bit. There's probably a little collapse. And so that's why, we might have kids with 4+ tonsils in our clinic that have normal sleep studies and like kids with 1 to 2+ that, have severe OSA. And granted, there may be other things, I don't know, or maybe they're otherwise healthy. And do the TNA and every once in a while they're still tiny, but a lot of times you pull it out with the atlas and you're like, okay, this is actually a 2 to 3+, it's just
Yeah,
sitting in
yeah.
the fossa
So the
better.
tip of the iceberg. Yeah. Yeah, yeah, yeah. Or the ones that are like they're just hanging on by a thread to begin with, and you're like, well, that was easy. Just a little
Hmm.
zip, and it's out. So I'll tell you my criteria for, and I'll see if my judgment is as good as a
Stop.
academic pediatric
Stop,
otolaryngologist.
please.
So one is, are the adenoids an issue? Right. So if they're huge adenoids, kid's a chronic mouth breather, that's going to lead to craniofacial abnormalities. And if they're snoring at the same time, and they're not responding to nasal steroids. And I almost always will try nasal steroids. Even if the adenoids are huge, I'll almost always try nasal steroids first. Because I've been very surprised. Uh, then I'll just do an intracapsular adenotonsillectomy, right? Because even if I'm not sure if it's sleep apnea, right, the adenoids have to go because the kid can get craniofacial
Right.
abnormality, they can get adenoid facies, dental issues from being a chronic mouth breather. So there's them. And then there's the kids who have loud snoring, witnessed apneic episodes, and inattention, hyperactivity, and enuresis. And
Yeah.
that's, for our pediatric colleagues, that's more common than like tiredness, right?
Yeah.
They're gonna be like the fidgety kid, the kid
Yeah.
that might get diagnosed with ADHD. And so those kids, I'm not gonna do a sleep study. I'm just gonna take out
Yeah.
the tonsils and the adenoids. What is a sleep study? Even if it says they have no sleep apnea, what am I gonna I'm not going to buy it.
No,
They've got
we
classic
do it
symptoms.
for
Yeah.
symptoms for sleep disorder breathing, which is not necessarily OSA.
Yeah.
I
And
think,
then
yeah, so,
if I'm on the fence, like,
yeah,
do they have sleep apnea?
absolutely.
Behavior's not, but a lot of times if they have like loud snoring but no daytime sequelae,
Yeah.
right? I will often observe those kids unless I've got some suspicion that they might have more severe, and then I'll order the sleep study. But a lot of times I don't even get a sleep study in them. Why? Because they're fine. They're fine
Yeah.
during the day.
Yeah. Yeah, no, for sure. So in terms of when I will always get a sleep study is definitely under the age of 2, and I actually will sometimes under the age of 3 as well. Although with the most updated, it's under 2 for sure, because those kids have a harder time in terms of post-op O2 requirements and things like that. Now, the kids that are high risk in terms of for severe OSA, they probably have it, but how bad is it and where are we starting with? Those kids, I'll get one in. So my kids with Down syndrome, and granted, the American Academy of Pediatrics recommends one by the time of the age of 4. My obese kids, and it depends because I usually say let's go ahead and start. It depends on in terms of let's get one, but and especially if they're morbidly obese. However, if the families really kind of listen, we just don't want to have to do the overnight. It's an extra cost. Then maybe we'll just go ahead and do it. And I usually keep all of anybody that's super obese, regardless of the sleep study, admitted anyways overnight. And then any kid with sickle cell, where there's sleep disorder breathing that we're thinking of taking out tonsils should get a sleep study before. Those kids are at high risk for hypoxemia, higher risk of stroke, things like that. My kids with craniofacial abnormalities, mid-face hypoplasia, super retrognathic, other poor tone, neuromuscular, there's other reasons. I may also get one as well. And so
Are you
those
talking
are,
about kids that have like snoring and witnessed apneic episodes, or you're just saying all of your kids that fall into these high risk categories for
I would
having
say,
OSA?
I would say 90% of my kids that fall into those categories that are symptomatic will get a sleep study before I take out tonsils and adenoids.
Got it.
Yeah,
So
except
if
I
they're
might
not
be,
snoring, then you won't get a sleep study,
well,
except for
all
the
the,
kids with Down syndrome.
yes, absolutely.
Okay.
Absolutely. Yeah. Yeah. Thank you for clarifying that. And then I agree with you. Anytime the history doesn't fit the picture, and that's going to be the 3 to 4-year-old otherwise healthy kid, not obese, know their medical problems, went to the dentist noticed that the tonsils were 3 plus, there's some mouth breathing, there's some hyperactivity, and maybe a light snore when they're sick. What do I want to do with that? And that it may be that we need to sit down and talk a little bit more in clinic about, behavior, things like that. But even that can be sometimes hard. And sometimes I'll go ahead and get a sleep study on those kids just to kind of get some concrete data.
So what happens when you get a sleep study on any of those kids? And again, I apologize to the general physician audience here. We're getting into the weeds in pediatric sleep studies, and their apnea hypopnea index is 5, right?
Yeah.
So they have borderline moderate sleep apnea.
Yeah.
What's the significance of that, right? Like if you have a kid who's
So
like, is their behavior, is that kid who's a little hyperactive, are you going to take them to the operating room and their behavior is going to significantly change? Like, I'm not sure what to do sometimes.
No, I think that that's a great point, especially in our adolescents. If you have a 16-year-old getting a sleep study at a pediatric center, their AHI is 10, they're going to be severe OSA. But if you, on adult guidelines, that's mild. And what are you going to do? Especially if their tonsils are 1 plus, you know what I mean?
Yeah.
So,
No,
but I do think
I'd say the same thing. I
Yeah.
interpret those. I'm like, look at you. You're like 6'3", 220. You're
an
bigger than
adult.
me.
You've
Like
gone through
you're,
puberty.
you're on the adult scale. I'm not comparing you to this like 45-pound 5-year-old. Yeah.
But the AHI of 5 an hour in a 3 to 5-year-old, I do think is significant because
Really?
that's every 12 minutes or so. If there's something going on, there's some sort of interruption. And if the family notices symptoms at home, I think that is very reasonable to go ahead and take them out. Yeah. I'm trying to think what else. A lot of, I would say maybe 10 to 15% of the referrals are actually coming from our pediatric dentists. I feel like the dentists are doing a lot more in terms of sleep screening because of sedation in their clinics and things like that. And so I think that's great, right? That screen is there. But then it also can be sort of, what do I do with this? What do I want to do with this? So.
Although my dentist did a head neck exam without knowing what I did, and told me that my hyoid was palpating my hyoid, and told me that I should get my thyroid evaluated.
Oh gosh. Yeah.
But we do appreciate those referrals from our pediatric colleagues whenever there's a concern.
Yeah.
So please keep sending those patients. We've been talking for a long time. We could talk for much longer.
Going.
Yeah. I was hoping
There's
we could get one tip on how to get wax out of the ears of small wiggly children. But we're going to have to save that in case there's a next time. So
that sounds good.
Because we've already been at this for almost an hour. So Dr. Gopi Shah of BackTable ENT podcast, thank you so much for your time.
Thank you, Brad. It's been a pleasure. I love talking shop with you. So thank you so much for having me.
That was Dr. Bradley Block at the Physician's Guide to Doctoring. He can be found at physiciansguidetodoctoring.com or wherever you get your podcasts. If you have a question for a previous guest or have an idea for a future episode, send a comment on the webpage. Also, please be sure to leave a 5-star review on your preferred podcast platform. We'll see you next time on the Physician's Guide to Doctoring.